Hello, my name is Curtis Pettaway. I'm a professor of urology at the University of Texas MD Anderson Cancer Center, and I'd like to talk today about germline predisposition for prostate cancer among African American and other minorities, and what's our state of knowledge. So the hereditary cancer syndrome genes and DNA repair gene mutations are very important in prostate cancer. We've come to know their importance. These genes are expressed at low levels in the population, but when they are present, because they are moderate to highly penetrant, when one has a gene alteration, it's likely to show up in a phenotypic expression. In other words, if you have the alteration, it's likely that you'll express the phenotype or the disease process clinically. And we know that they have a significant clinical impact with respect to the early detection of prostate cancer in other cancers, both in the patient and the patient's family, again, since this is germline DNA. We also know that some genes are associated with enhanced metastatic and lethal potential, such as the BRCA1 and 2 genes, BRCA2 especially. And we also know that expression of these genes, specifically in the metastatic prostate cancer scenario, can be important predictors of response to certain types of therapy, such as cisplatin and the PARP inhibitor family of therapies. So the question is, given the importance of these genetic variants, what do we know about these in racially diverse populations? You would think we might know a lot, and it's very interesting because prostate cancer is certainly more common in African Americans, and we know the mortality is twofold higher. Yet, prior to the era of multi-gene testing, and even up to right now, actually very little is known. So we're going to actually review what is known today. When I reviewed this topic a few years ago as part of the Philadelphia Genetic Consensus Conference on inherited genes that potentially are part of hereditary cancer syndromes. At that point in time, there were few studies among African Americans and other Asian and other minority populations. In fact, 2 studies at that time using single gene testing really showed that amongst a fairly large cohort of African Americans, some with early onset prostate cancer, the BRCA1 and 2 mutations were virtually not noted in either of these studies. When we looked at another hereditary cancer gene, the HOXB13 mutation, which predisposes for the development of prostate cancer, specifically looking at the G84E mutation, which is the one that is written most about. Again, these 2 studies showed that this mutation was rarely found in African American populations. However, there was another novel mutation in the HOXB13 gene that was found in African American patients, but the actual clinical significance of this deletion has yet to be discovered. Similarly, among Chinese populations, again, this G40E mutation was not present in 96 unrelated prostate cancer patients, but they did find another novel HOXB13 genetic mutation in 3 patients in another study. So what we can say is that at least up to this time, in some of the more prevalent mutations that were studied, we didn't see this among African American and Asian patients up to that time. With respect to the Lynch syndrome genes, which are again associated with another hereditary cancer syndrome involving colon cancer, certainly renal cancers, hepatobiliary cancers. There were 23 studies that were reviewed in a large review at that time. And again, amongst these studies, all of the patients studied were Caucasian, and there was virtually no data that could be identified in minority patients. So up to that time, we knew very little about the expression of these genetic variants in hereditary cancer syndrome families. Now, a landmark study came out looking at DNA alterations in men with metastatic prostate cancer. And this was one of the first studies to show that these mutations actually were common in men with metastatic prostate cancer. And in fact, about 12% of the men with metastatic prostate cancer had a mutation in one of these DNA repair genes. And this frequency was increased over that in localized cancer. So it seemed like these mutations were much more common in metastatic prostate cancer than in localized disease. And you could see using the data on the slide that these mutations were present not only in Caucasians, but also in Black patients, Hispanic patients, and Asian and Pacific Islanders. And although the numbers are low, the frequencies were really not that different in all of these populations, again, with the stipulation that the numbers are relatively small. Importantly, if you had one of these genetic alterations, 71% of these men that had a mutation like this had a first-degree relative with another cancer. So we can see that the presence of this mutation was important not only for the patient, but also for other family members. Another important paper that came out about 2 years ago at the same time as the Genetic Consensus Conference was from the group from Hopkins. And they looked at the issue of expression of these genetic alterations, specifically two types. One, two genes of the DNA repair family. One gene was called ATM and the other one was BRCA1 and 2. The BRCA genes are certainly very familiar to most clinicians. That's certainly associated with the hereditary breast and ovarian cancer syndrome. And what they found was that if you had a mutation, you were likely to die at a younger age, the time to death was shorter, and when you looked at that time, among carriers, the time to death was 5 years compared to 16 years in non-carriers. So these genetic alterations certainly were associated with a lethal phenotype. And what we see here is that we also see that when you compared the incidence of these mutations in men with localized cancer versus lethal cancer, in virtually every incidence, either BRCA1, 2, or ATM, the incidence was higher in men with lethal cancer. And as we also saw in patients in the other study looking at a variety of different genes, in this study looking at BRCA1 and 2 and ATM, African Americans were noted in at least one case, small numbers, to have ATM mutations, and Asian patients were noted to have both ATM and BRCA2 mutations. So these types of data showed us that these DNA repair gene alterations were common in minority patients, where, as in prior studies, we hadn't really seen this. And as a result of the landmark study by Pritchard et al., where they looked at DNA repair gene alterations in metastatic prostate cancer, and also as a result of the Philadelphia Genetic Consensus Conference in 2017, I believe that these types of data and compilations led to revising the National Comprehensive Cancer Network guidelines for the first time, where considerations and recommendations for germline, that is testing the blood DNA, and somatic testing, meaning testing the tumor DNA of an individual with cancer, were first recommended. And with respect to germline testing, there were considerations for germline testing along the whole spectrum of prostate cancer, for men, from men with very low risk disease to men with very high risk and metastatic disease. And so we'll hear a little bit more about this as we go forward. But this was the first time that genetic testing really came on board with respect to specific recommendations, especially in the United States. Subsequent to the NCCN 2017 and 18 recommendations, 18 what we talked about more recently, this very large study was published by the group at Tulane University in New Orleans in collaboration with one of the commercially available genetic testing companies. And they looked at data on over 3,000 men, so a very large study of patients with prostate cancer who actually did undergo genetic testing. And they underwent genetic testing irrespective of family history, age, or clinical stage. And we don't really know the actual indication for testing in the individual patients, but suffice it to say, these men with prostate cancer underwent genetic testing. And the group was very diverse with respect to racial and ethnic group, as you see over here. And they considered men who had positive variants, only those variants that were likely to cause a pathogenic finding clinically. And so when they looked across the spectrum of disease, across the spectrum of the different cohorts, the incidence of mutations amongst this very large group of men was actually quite high. It was about 17%. And when you actually looked at who had the highest incidence of mutations, it was the Ashkenazi Jewish population and the Caucasian population. Black patients and Hispanic patients had a slightly lower incidence of mutations, and the Asian population had a similar incidence to the white population. Interestingly enough, we think of these genetic alterations potentially being more common in men with a family history of prostate cancer or other cancer. But in this particular study, the incidence of mutations was not affected by family history, patient age, or Gleason sum. So men with low Gleason score cancers had a high incidence of mutations, as men with higher Gleason sum cancers. they actually stratified the different types of genetic alterations that they saw in this population. And this slide shows some of the more common alterations that they noted in their study. And we see this compared for white, Black, Asian, and Hispanic patients. The blue font indicates genes that would be recommended on the NCCN panel for testing of men with high, very high, or metastatic prostate cancer. And it's very interesting that when you compare the different groups, white, Black, Asian, Hispanic, certainly among the Black and Asian cohorts, one saw very similar patterns of genes that were altered when compared to what the NCCN recommendations for testing would recommend. But there were some differences amongst the various cohorts with respect to genes that were expressed, genetic alterations that were expressed or not expressed. The most common alteration was BRCA1 and 2 amongst virtually all of the groups. And this is certainly consistent with other series as well. And again, in the area of multi-gene testing, we see that these genetic alterations in genes associated with either hereditary cancer syndromes or DNA repair are expressed among minority populations. With respect to BRCA1 and 2 and ATM, there was a lower incidence in African American and Hispanic patients. And with respect to the CHEK2 mutations, which are again DNA repair alterations, there was a lower incidence among the minority cohorts. And certain genes were unique among certain groups of men, such as the RET and the SMAD4 alterations. In this study, they were unique to the Hispanic population. So there is some heterogeneity. Another study looked at individuals that were diagnosed and were suspected to have a diagnosis of a hereditary cancer syndrome. So they met the criteria for a hereditary cancer syndrome. And the group here from Philadelphia asked the question, one, is there a history of prostate cancer in these families with hereditary cancer syndromes? And secondly, they asked the question, after reviewing the pedigrees, is it probable that the prostate cancer could be linked with the hereditary cancer syndrome? And in this study, there were 345 individuals. Most were white, 292, and there was a small subcohort of African American men. Interestingly enough, amongst the cohorts, 220 prostate cancer was felt to be linked to the hereditary cancer syndrome. And it was equal in African Americans and Caucasians, 75% the time in African Americans and 61% in Caucasian. And when they looked at the hereditary cancer syndrome that was most commonly linked to prostate cancer, it was the hereditary breast and ovarian cancer syndrome. And in African Americans, this was increased compared to Caucasians. When they looked at genetic testing among the individuals who met the criteria for hereditary cancer syndrome, who had a family member that was linked to a prostate cancer diagnosis, the overall incidence of mutations in these individuals was high, 19%. And it was no different among African American or Caucasians. So among these families with a hereditary cancer syndrome linked to prostate cancer, the incidence of these genetic alterations was similar for African and Caucasians. But of note, the types of mutations were different. For Caucasians, they exhibited both BRCA1 and 2 mutations, as well as other DNA repair genetic variations and other mutations. However, among the African American cohort, they only exhibited BRCA1 and 2 mutations. Again, this may be related to the small numbers, but it certainly could point to, again, the diversity of genetic alteration among men of different racial and ethnic groups. So what do we know now in 2020? Well, one thing we do know is that multi-gene testing panels are certainly becoming much more common, with a number of companies offering this testing. The cost is coming down. That increases the availability, and the number of variants that are being found is increasing. And among prostate cancer patients referred for genetic testing, we find that genes associated with hereditary cancer syndrome and DNA repair do occur in minority populations such as African Americans, Asians, and Hispanics. And based on this information, it would appear that the NCCN 2019 recommended multi-gene testing panel should continue at this point in time. In other words, we wouldn't recommend stopping this testing among African Americans or other minorities, or among other groups as well, because this will allow us to gain new insights, potentially into the management of local disease. Perhaps will enhance our existing knowledge on the management and treatment options for metastatic and lethal disease. And knowing whether one may have one of these variants certainly could be important for other family members for counseling with respect to risk related to prostate and other cancers. Among African Americans that are suspected or meet the criteria for hereditary cancer syndromes, if there is prostate cancer in that family, it certainly raises an important point for clinicians to be aware of this and to take a thorough family history, because this could be important for that patient and also for the family members. Certainly, among populations where there may be issues with respect to access, we must find ways to provide access to these populations to gain access for genetic counseling and testing in the appropriate scenario. So we want to make this testing widely available, and we don't want this to be a barrier to gaining new knowledge. What do we need going forward? Given these insights, the availability of testing, and our relative lack of knowledge about the importance of these variants among African Americans and other minority populations, longitudinal registries certainly should be considered from the standpoint of view of research. These registries should include African Americans and other minority populations. where one takes detailed clinical and family history information on these patients. Certainly, large genetic sequencing efforts should occur so that we can determine the incidence of alterations with respect to DNA repair alterations or other genes that might be important in prostate cancer. And then we need long-term longitudinal follow-up. And the goal of this type of research would be to optimize defining the role of these rare genetic variants in management and counseling along the spectrum of prostate cancer disease states, from low-risk disease to metastatic disease. For instance, what do we know about BRCA1 and 2 mutations in low-risk prostate cancer? Should these men be offered active surveillance? This is the kind of information, this is the kind of study that we need going forward. We certainly already know that the presence of certain types of mutations in men with metastatic prostate cancer can certainly serve as a predictive biomarker for response to therapy. We also will learn about the incidence and types of other cancers. This will certainly be valuable for counseling other family members. And then the culmination of having this data repository, data and clinical repository, will be that we'll be able to rationally define which genes are most important to be included in future multi-gene testing panels recommendations for clinical care. So I've given kind of a status of what we know at this time and future directions, and I thank you very much for your attention.